And we're back. This is Lecture 13, Somatosensory System. 3 of 3. Get ready for the big finale, baby. Here we go. We still have our picture here. We are talking about different tracks. And there's 2 tracks we spoke about. You have the dorsal, lateral, medial lemniscus tract, which is going to be in blue for us. It's also the sensory pathway for touch, vibration, and proprioception, which is TVP. TVP, touch, vibration, and proprioception. You also have the other path, which is the anterolateral system. That's a sensory pathway for pain and temperature. As you can see, it comes into the anterolateral portion of the spinal cord, and it's going to cross over. It's going to go to the contralateral side, whereas the dorsal root ganglia, or rather this dorsal lateral medial lemniscus, is just going to stay on the one side. There's 2 clinical correlates we need to know. One is called Brown-Séquard syndrome, and the other one is called syringomyelia.
So if we start, we can look, we'll start with Brown-Séquard syndrome, which is a hemilateral lesion of the spinal cord. So if we look at this picture right here in the middle, what we're seeing is that we have an occlusion at T4, at the level of T4 on one side. Hence, this is hemilateral. This is Brown-Séquard syndrome. It's a pretty rare syndrome. And what we're going to go through is we're going to go through the different examples of how we can have an ipsilateral and a contralateral, and if the sensory signal is still working or if it's inhibited by this occlusion at both levels, at the level of the lesion and a sensory loss below that level of lesion.
Yeah, so to break down the chart, what this chart is saying, if it looks great. So what this is saying is that you have sensory loss at the level of the lesion. So if you have sensory loss over here, this is going to be our 1, 2, or 1 and 2s. That's what we're going to run through here. Sensory loss at the lesion and what happens when you're trying to get pathways to come in. And then we're going to go down and talk about sensory loss below the level of the lesion, which means if you have sensory fibers that are trying to get in, what are they going to do, or what are they able to do if they reside below the lesion, right? So we're going to go right into it right away. So the first thing we have is we have the TVP, touch, vibration, proprioception, which is our dorsal lateral medial lemniscus pathway. The first thing we're looking at, which is in blue, right? It's number 1 you could see here for blue. Over here, this is going to be your dorsal root ganglia, right? What can this dorsal lateral medial lemniscus pathway do? It's supposed to come in and synapse at the dorsal column and then go up to the next pathway, right? Or go up to the next
thalamus.
Or it's supposed to go up to the thalamus, basically. In this case, because there's a lesion at this specific level, right?
On the same side,
on
ipsilateral.
the same side, which is ipsilateral, you come in and you can't have any input.
You lose the sensory loss. So there's sensory loss.
There is sensory loss.
So you do not feel touch, vibration, or proprioception. So all 3 of those sensories have been lost.
Yes, when it's on the ipsilateral side.
On the ipsilateral side at the T4 level.
So if we go to the same one, if we go to pain and temperature, which is our other pathway, again,
the anterolateral system.
If it's on the ipsilateral side, which is the same side as the occlusion, again, you're not going to be able to have any kind of signal.
Perfect.
Okay.
So then on the contralateral side,
which means opposite side,
for the dorsal lateral meniscus, which is 2 in blue, it can come in at the dorsal column, and then it could go to synapse there and then ascend to the thalamus.
Yes.
Which is functioning. That would be why you can see that there's a check mark here, because as it comes in, hey, there's no occlusion on this side, on the right side. I can go straight up.
Yes.
Which was opposite on the other side where it came in and there's an occlusion. So it could not function.
Yes.
However, now we look at the anterolateral system, which is for pain and temperature. And we're on the contralateral side.
Yep.
And what you can see is that we know that this pathway comes in this way and then cuts across and then synapses here.
Yes.
So you would think maybe it doesn't work because there's an occlusion on this side.
Yes.
However, what we spoke about was that we have Lasar's tracts. So what you can do is as it comes in, instead of coming down here and going to the occluded side, we can actually take Lasar's tracts, go up to the level of T3, and then we can cut across and reach the thalamus. So the signal is not lost. For pain and temperature, we can get around the occlusion because we have the ability to climb, to ascend, or descend using Lasar's tracks.
Yes, and you can climb and descend. You can ascend or descend to the level of 2.
Up to, down to.
Yeah, up to or down to spinal levels. So even if we had to go up one more level, if there was an occlusion here, you would be able to do it. You would come here and say there's occlusion. You would go up 1, okay, there's still an occlusion. You can go up 2, and you could synapse up top. If that's the case, you could also go down 2 if you needed to. So that's there. So really, you have a check mark here on the contralateral side for pain and temperature, because pain and temperature, it can't go there, but it can use Lasar's track to go up 1 and synapse there up to the thalamus. So it says, yes, you can do it via Lasar's track. Now, let's take a look at sensory loss below the level of the lesion. So we still have our same lesion here. It's happening here at the level of T4. However, now we're synapsing, or we're at least starting our pathway at the level of T5. So for the first thing we're going to look at, it says touch vibration proprioception. This is our dorsal lateral medial lemniscus pathway. It starts right here at the dorsal root ganglia. It's going to come in, synapse at the dorsal column, and then ascend up. Oops, wait a second, there's a lesion right there. So what does that mean? It means on the ipsilateral side, which is the same side, you cannot have your sensory input. Boom. Let's look at now, we'll go, I guess we'll go, where do you want to go next? Which one? Down one?
Yeah.
All right, so now we're looking at the anterior lateral system for pain and temperature on the same ipsilateral side as the occlusion. However, we're looking at below the lesion. So here you are below the lesion. What's going to happen with this guy? We know he comes in, he synapses at the dorsal root. He's going to cross over, synapse here at the anterior lateral portion, and then he's going to ascend upwards. That's fine. He could do that. Give him a check mark.
And the last is the contralateral. So if we look at the contralateral, we're looking at 4 in blue, which is for touch, vibration, and proprioception, the dorsal lateral medial lemniscus. And what we know is that it goes and synapses at the dorsal column, and then it rises to the thalamus. And because there's no occlusion on this side, we know that it's okay. We'll give it a check. Now, if we do the same thing for pain and temperature, so if we do pain and temperature right here, we see that starting on the contralateral side, as it comes down, it synapses in the dorsal root ganglia, or the dorsal root.
Yep.
Not dorsal root ganglia, but dorsal root.
Comes from dorsal root ganglia.
Yep.
Okay.
It cuts across. As we cut across, right, it synapses at the anterior lateral system. But the issue is now we have to climb up. And when we climb up, we reach the occlusion.
However, this is big right here. So don't end the video right now. Do not end the video right now. It's not over. We have one more thing we need to add. Here, even though we drew this, that we said, hey, at the level of T5 going to T4, we said you would come across contralaterally for our pain and temperature. You would come across, you would not be able to synapse upwards. However, because we're only one level away and we have the ability to go plus or minus 2 spinal cord levels away in order to use our Lasar's track, we could utilize Lasar's track in this case, and we would use Lasar's track. So what would happen is you would come in from this anterior lateral system, you would come down, you would synapse here, and then instead of crossing over, you would simply ascend up, you would synapse here, you wouldn't be able to go, so you would synapse here and you would go up to the next spinal level. So that's going
And they
1,
cut across.
2, yes.
And then once you cut across, you're able to go to the thalamus. So what happens?
So realistically, yes, you could have a synapse or you could have
So
a
pain
signal.
and temperature would not be lost
No.
as long as it's within the 2.
And in this case, it would have been within the 2. So that really could be a check
In this
mark.
case, yes. And now let's say we're at T7.
Yeah.
T7 would be too far away from the injury.
Yeah, if you were down further, you wouldn't be able to do it. Okay.
Or even if you were at T6, for example,
Yeah, if you were at T6, you would ascend up 1.
just to T5, right?
Yeah. And then that's it. You would stop basically. So maybe you would lose some sensory input. Okay.
So then the next thing that we're talking about is another disease, clinical correlate, which is syringomyelia,
Yep.
which is a degenerative lesion to the center of the spinal cord, which then fills with fluid. It forms a cavity or a cyst, also known as a syrinx, which is a bilateral occlusion of the interior white commissure.
Yep.
So what you can see is the occlusion right in the center. So here in the brown sequard, we said it was hemilateral. Here in syringomyelia, it is a bilateral. Both sides are occluded. And this is mainly due to a cervical injury. And what you can see is if we look for the anterior lateral system and we're talking about pain and temperature, because they both have to, regardless if it's ipsilateral or on left or right side, it has to cut across the spinal column. So because it cuts across, both of them would be occluded because they have to go through the middle. If we didn't have to go through the middle, like in the dorsolateral meniscus, then this would not be an issue. But because we have to cut across, we lose pain and temperature. But touch, vibration, and proprioception of the dorsolateral medial meniscus pathway is intact. It is not affected in syringomyelia.
And then also we noticed that this is mainly due to a cervical injury. We said it's possible that a patient can get into a car crash years prior, but then they can have the degeneration of the spinal cord as the years go on, and it could lead to a cavity, potentially filling with fluid, and this could lead to our clinical correlate here. Also, because it's bilateral, some kind of buzzword or just to think, you would think of a patient coming in with symmetrical or bilateral loss of pain and temperature on both sides of the body. So that's something to think about
And
as
then
well.
Another thing is, what is this similar to, right? If you were going to think about a degenerative disease where it fills up with fluid, what is syringomyelia most similar to?
We said it was ex vacuo, what is it?
Hydrocephalus ex vacuo, because it is a communicating hydrocephaly, right? And we know that that is also a degenerative disease where the brain now degenerates, right? And then fills with fluid, right? Because the ventricles expand. Here in syringomyelia, same exact thing,
cavity.
But now instead of being the brain, we're talking about the spinal cord.
Okay.